Welcome, everyone. And for those of you who've been with us for the full 2 days, thanks for sticking around. Made it to the very last breakout session of the 2-day conference. It's been a packed conference, great content, but I'm sure you're all really exhausted as well. So thank you for being here. Hopefully folks can hear me all right. Only so much. All right. Better? Awesome. So I'm Karen Matsuoka. I'm a senior policy advisor for health equity at CMS, where I help to oversee and coordinate all of the Medicaid and CHIP equity efforts. And I want to just sort of provide some framing and context for this great packed panel of experts. You're in for a great treat. To say a little bit about why we care so much at CMCS about maternal health. It's always been an area of focus for us at CMS because nearly 2 out of every 3 adult women enrolled in Medicaid are in their reproductive years. Also, Medicaid covers over 40% of all births in this country. And as you'll see in this slide, for some states, that number can be as high as 70%. Can folks see? Am I blocking? Okay. But if you're here, it's probably because you also know that the United States has the highest maternal mortality rates among all developed nations, and that within the United States are Native American and other Pacific Islander, Black American Indian, and Alaska Native populations have the highest rates of pregnancy-related deaths, as well as the highest rates of severe maternal morbidity. And when we look at some of the key clinical drivers of maternal mortality and morbidity, we see that disparities are there as well. Whether that's the percentage of deliveries that were preterm or the percentage of births that were delivered by C-section, even when doing so would unnecessarily expose mothers to higher morbidity and mortality risk. And because so many of our people rely on Medicaid and CHIP for their maternal health care, and for some populations, the African American population, for example, and the American Indian and Alaska Native population, 2 out of 3 births are covered by Medicaid. We believe that the Medicaid and CHIP programs have not only a unique opportunity to do something about this, but an important responsibility to reduce disparities in maternal health as we work to improve health outcomes overall. We're doing this by taking a very comprehensive view at all the drivers of the poor outcomes that we're seeing. And that means looking not only at the clinical drivers of these outcomes, like the ones that you saw on the prior slide, preterm births, unnecessary C-sections, timely and frequent prenatal postpartum care visits. But we're also looking at things like non-clinical or social drivers of health, things that, according to the evidence, can oftentimes swamp the outcome on health outcomes relative to the healthcare that individuals are receiving. So we're looking at things like social drivers like food and housing insecurity, also transportation barriers. You can imagine that it does no good to have Medicaid coverage and have high quality prenatal care if you can't even get to your visit. So we're measuring these outcomes and their drivers, and then we're stratifying them so that we see not only how we're doing overall for the beneficiaries that we serve, but to start to get an idea of where the disparities are, whether that be by race, ethnicity, rural residents, urban residents, whether you have a disability, whether your language, primary language is English or something else. And then we're also looking at, uniquely for the Medicaid and CHIP programs, what we're calling policy drivers of these outcomes. So a program like Medicaid and CHIP, there are federal policies that we in CMCS set, but for the most part, the actual administration of these programs are left to the state level. So states have a lot of choice in terms of how they administer their programs, what benefits they cover, what they reimburse for. So as we're looking at all the different things that drive health outcomes, we're also taking a look at these policy drivers of health. Things like, are states offering 12 months of continuous coverage in the postpartum period now that they're authorized to do so, even if they don't have to? Are they covering for things that are evidence-based, like home visits? Are they reimbursing for care that's provided by workforce that may be non-traditional but can make a huge difference, like doulas? And we're looking to see how outcomes improve over time and disparities shrink as we make policy changes and achieve improvements on each driver. So to tell you a little bit more about what all this looks like, we've organized a great panel for you. We're going to kick it off with Ella-Marie Whelan from CMS for an in-depth look at what the latest CMS data tell us about the state of maternal health equity in Medicaid and CHIP. And then with that data as context, we'll then turn to Kristen Zycherman of CMS and then Megan Wu of NORC at the University of Chicago. We'll discuss efforts underway both within CMS, but also at the state level to do something to improve maternal health equity in the Medicaid and CHIP populations. And then, really exciting, we're going to cap things off with two speakers, Linda Jiang from Lyft, the rideshare program that I'm sure we're all very familiar with, and Greg LaManna, who is the CEO of Anthem Blue Cross Blue Shield, who participates in the Ohio Medicaid program, who are going to give us a glimpse of what they're doing on the ground right now that's already making a difference for the populations that we serve. Bios are all available on our website, so I'm not going to take up critical time just to go over their impressive backgrounds. And without any further ado, I'm going to turn it over to Ella-Marie.
So, thank you, Karen. Yeah, thanks. So I'm Ella-Marie Whelan. I'm the Chief Population Health Officer at CMS Medicaid, and I also help coordinate the maternity work. And today we'll be talking about. Today I'm going to be talking, giving you a sneak peek of a health equity data brief that we're working on now. This is the next in a series of health equity briefs that we have done using our Medicaid data. The first we did was race ethnicity, and we did a deep dive into that. All of these are available on our website as well. And then we started looking at topics. We did disability, mental health, primary care, rural, and well child care. And now we're working on a maternal health equity brief. So I'm going to give you a sneak peek of some of the stuff that's in there today. And so these are two different slides, kind of back and forth. I'll start on the left. One of the things that I just wanted to do is kind of let you know, who do we cover? So we cover 42% of all births. And as you saw on the slide that Karen just presented, in some states, it's almost 70% of births. So we take this really seriously. The distribution of who we cover and the colors of the race and ethnicity will say the same for my presentation. So the orange, you can see there, 40.5% of all the births we cover are non-Hispanic white. The dark blue there is Hispanic, 30%. Almost a quarter of the births are non-Hispanic Black, 3.8% are Asian Pacific Island, and then a tiny less than 2% are Asian American Indian Alaska Natives. But you'll see these colors vary as we start to look at disparities. So then the next thing is, that's the 100% of the births. The next thing is, what percentage of those births are premature? And you can see the colors switch, right? There we have African American, non-Hispanic Black, 13.5% of those births are premature. And then you can see it goes down there later. The second is that American Indian, Alaska Native, and going down there. And this is in all for 2021. So the next one, there's a couple different things. The first thing I want to show you is there's a regional distribution of prematurity as well. So this is not state by state, these are regions, and there's a reason we don't show you state by state yet, but you can see the darker the color is the higher percentage of births that are premature, and the lighter color is about 9% of those births. So the West, you can see about 9% of those births are premature. The gray are states that we don't have any data for, so try to not see that. But you can see in the lower right-hand corner, you can see where those colors get darker. The other thing that we are now looking forward to being able to do, because we've got these data over time, is looking at change over time. So now if you kind of look really carefully, and I don't know whether you can see because of the saturation of the colors, but over the 3 years, the colors are getting darker uniformly. Every state from between 2019 and 2021, the percentage of prematurity is getting higher and higher. And so we're going to start to look into this. And as Karen said before, we're just not looking at these numbers as an FYI. Once we get this data, we are looking for policies and ways that we can make a change in this stuff. This next one is severe maternal morbidity. Over the past 3 years, the same three issues were pretty much the same for over the past 3 years of the causes of severe maternal morbidity. On the left is sepsis. The middle is adult respiratory distress syndrome, or ARDS, and the third is acute renal failure. Same across all three, but look at the change over time there. Each of those orange is showing a difference from 2019 to 2021. So sepsis has gone up. The middle one, though, ARDS respiratory, that went from 16.5 births per 10,000 to over 30% of births per 10,000. Probably because of COVID, not really sure, but we're wanting to track that and figure out what that is. And then acute renal failure, again, all of them have gone up over those 3 years. Now, the next is, though, when we break those three issues down by race and ethnicity. And again, you can see the same colors. Look at sepsis, that less than 2% of the American Indian, Alaskan natives, 43.5 live births there were because of sepsis in that population. And you can see then it goes down in sepsis, followed by, which is interesting, Asian Pacific Islander, which was the lowest in prematurity, and it's now number 2 when we're looking at sepsis. Then you go to the middle, ARDS, and you can see American Indian, Alaskan Natives are still the first, but you can see the non-Hispanic Black in the yellow that popped up there too. And then when we move to the third, acute renal failure, number 1 is non-Hispanic Black at 34 almost 35 individuals having that per 10,000. So again, we know what the rates are generally, but then when we start to dig in, we can better understand how that looks for the populations. And that's why it's so important when we work with states, and you'll hear from Kristen, that we help states figure out what do they want to do based on their population. So they may have different interventions based on who it is they're trying to serve. And my last slide here, this is hard to see, so I'm just going to talk you through. In this one, we looked at the odds ratio. So the odds of you having prematurity or a condition of severe maternal morbidity, looked at race, but then we also looked at disability and we looked at age. And again, this is a sneak preview. You'll see a full paper on this coming up. When you look at the odds ratio, so the odds of having a preterm birth, if you're non-Hispanic Black compared to the white population, you are 15 times more likely. For still in prematurity, when you're looking at the rate of having a severe maternal mortality, if you are disabled, you are 55% more likely to have a premature birth. And the last is age, as the older women are 14% more likely to have prematurity. That's the blue. When you look at the orange, this is the rate of the odds of having a condition that's considered a severe maternal morbidity. And for African Americans, it's 21% higher. Look at the orange, which is over here for disability. If you are disabled, you have a 132% increased likelihood of having a severe maternal morbidity, maternal condition of severe maternal morbidity. And the last is there for age. You are 22% more likely to have a condition of severe maternal morbidity if you are increasing age. So again, this is a sneak preview. There's other things we're looking at. We wanted to share this with you now. And most importantly, we want to now show you some of the things that we're trying to do to address it, because this is unacceptable. We know it's unacceptable. And now we're not just reporting it. We want to find ways to try to help improve it. Kristen.
Thank you all for hanging in there for our last session of a 2-day conference. We appreciate you all still being here. I'm Kristen Zycherman. I'm a technical director for quality improvement in the Division of Quality and Health Outcomes at the Centers for Medicaid and CHIP Services. I'm a white woman with short dark hair, and I am wearing a navy suit with a Ask Me About Medicaid with a pregnant person on it. And so getting started here, why focus on postpartum care? So the Maternal and Infant Health Initiative was started in 2014 as part of improving care for Medicaid and CHIP beneficiaries, both during pregnancy, postpartum, and during infancy for our beneficiaries. So when we reconvened in 2019 to be able to kind of modernize those recommendations as times have changed, we've kind of headed in the wrong direction as far as maternal morbidity and mortality. The expert work group said that postpartum care was one of the things that not only was high impact for our population, but also was something that Medicaid and CHIP had a great ability to influence. So in the center of that Venn diagram was postpartum care. And we know that 65% of deaths occur in the postpartum period. And we also know that about 80% of them are preventable. So this is an incredible opportunity to improve. Why do Medicaid and children's health insurance programs need to focus on postpartum care? Well, we know that there are disparities within this. That, for example, the rate of postpartum care follow-up among people with diabetes and hypertension, which we know are major drivers of maternal morbidity and mortality, ranges from 5.7% to 95.4% across the states. So obviously, wherever there is great variation, there's great ability to improvement because someone's doing it right, and some states need a little bit more help. In addition, we know that the postpartum care visits among Medicaid beneficiaries is lower than for the private insurance population, and that some conditions, for example, postpartum depression, is higher among those who have lower economic status and people of color. So we're going to talk about how we are succeeding so far. And one of the ways is the first step to people accessing care in the postpartum period is to have coverage in the postpartum period. So I'm sure we have beat that drum a couple times during this conference, but we're still excited about it. That 46 states plus the US Virgin Islands and DC have extended postpartum care coverage to 12 months. And if you think about all the things that need to happen during that postpartum period, all the follow-up care, the handoffs, the making sure that chronic conditions are being taken care of, that is a lot to happen in the previous 60 days offered, and having that full 12 months really opens up that ability to improve. Then a little bit more about the Maternal Infant Health Initiative. I talked about how we had the phase 1 in 2014, phase 2, we had our expert work group reconvene, and we focused on decreasing cesarean births and low-risk pregnancies to improve maternal outcomes, increasing the use and quality of postpartum care visits, and increasing the use of quality of well child visits. So we have a lot of information on those on our website, which I would really want everybody to go to, because we also, hot off the presses, so it didn't make it into our slide presentation, was that we just released a new Medicaid and CHIP beneficiaries at a glance maternal health infographic. And it has a lot of great statistics on demographics and all of those things on there. So we want people to take a look at it, because one of the graphics that really stuck out to me in that was that the highest cause, or the most common cause of maternal mortality across the board, was mental health and substance use disorder. But if you break that down by race and ethnicity, which we did, that's true for the white population. It's true for the Hispanic population, but for non-Hispanic Black birthing people, it is not. It's hypertension and cardiovascular health. Cardiovascular causes of death are the leading cause of Black maternal death. So we wanted to make sure that in our phase 3, kicking off now with our summer webinar series that is happening currently, that you can also register for here, that those two topics really kind of would help to reduce those disparities, because we're attacking the drivers of maternal death for across the entire population and not just for certain races and ethnicities. That a little bit more about our kind of larger quality improvement technical assistance program. Over the course of the topics we have done in NIHI, as well as some other topics as well, we have a variety of tools online that we encourage you to access, getting started with QI videos. We have highlights from our previous affinity groups of what states have done, what has worked. We have a measure strategy, as well as driver diagrams and change activity tables. And to learn more, you can email us and we're happy to help. And then this is just a little bit more. Our postpartum care toolkit is one of our newer offerings that we had as part coming out of our postpartum care work that is really geared towards states and their care partners to of strategies to increase the rate of postpartum care, but also the quality of postpartum care. So different strategies, federal authorities, evidence-based state call-outs of things that have worked in other states are all in there, as well as a checklist to kind of help keep you organized as you're trying to improve. And that is all for me. Thank you very much. And now Megan.
Hi, everyone. My name is Megan Wu. My pronouns are she, her. I'm a multiracial woman, Asian and white. I'm wearing a black shirt and blazer and a multicolored skirt. I'm a senior research scientist at NORC at the University of Chicago. We have a longstanding contract supporting CMS's Office of Minority Health to help them advance and work towards achieving health equity. As part of this contract, I led an assessment to better understand efforts to improve quality of postpartum care at the state level. My colleagues who supported this work are listed on the slide as well. This was a three-part project. We developed data visualizations using TMSIS data, and we also conducted qualitative interviews with state officials. But the work that I'm going to highlight today focuses on our review of state managed care initiatives to really understand what states are doing to target and improve postpartum care. The purpose of our review was to understand postpartum care data quality, to understand state-level managed care postpartum quality approaches and regulatory requirements, and also identify postpartum disparities in postpartum care at the state level, as well as interventions that states are engaging in to address those disparities. We reviewed and extracted information from CMS's Medicaid managed care quality improvement resources. As many of you likely know, CMS requires state and CHIP agencies to develop and maintain a quality strategy to improve the quality of healthcare and services provided by managed care plans. Components of the quality strategy and requirements are highlighted on this slide, including the documents that are required to be reported. We conducted a systematic review of quality strategies and annual EQR technical reports for all states who had at least one Medicaid or CHIP agency with at least one Medicaid or CHIP managed care plan. So in total, we reviewed documents for 44 states, Washington, D.C., and Puerto Rico. We systematically reviewed and then extracted information on goals and objectives related to postpartum care, performance measures that states were using, performance improvement projects or PIPs that they were implementing, and also EQR recommendations and actions. So in terms of key findings from our review, we found that most Medicaid programs included are making efforts to improve postpartum care. In total, we found that 27 states had a goal or objective related to postpartum care or maternal health more largely in their quality strategy. There was a wide range of initiatives and activities that were being implemented across these states. They included implementing postpartum specific performance improvement projects, including postpartum measures in value-based payments, taking on statewide maternal health initiatives, as well as working directly with MCOs to improve their rates. The most commonly reported postpartum care measures that we found in the reports were the HEDIS, prenatal, and postpartum care measures. In total, 34 states that we reviewed had reported the postpartum care measures in their EQR. We also found that postpartum care initiatives often took place at the MCO level. We found that 10 states, Iowa, Mississippi, Washington, D.C., had at least one MCO with a postpartum related PIP. There was a lot of variation in terms of what those states were doing and who they were targeting. Some focused on prenatal and postpartum care for the whole beneficiary population, providing incentives or education and training, while others oriented towards a more specific subpopulation, like a specific at-risk racial and ethnic group or a group within a specific zip code. So it really varied. As a result, the impact of PIPs on postpartum care outcomes was difficult to evaluate. We only found one state, Indiana, who reported significant improvements in their postpartum care measure after PIP implementation. We also, and some states just weren't far enough along in their implementation to be reporting data yet. Others reported no change, and a few reported worse outcomes, unfortunately. We also discovered that few states are really explicitly calling out and addressing equity within their postpartum care strategies or measures. We only found that 3 states, California, Washington, and Rhode Island, are stratifying their data and postpartum care measures by race and ethnicity or other sociodemographics like language or region. So that's definitely an area for growth and improvement. Our findings also highlighted some themes related to data. We found that when we did compare TMSIS values of the postpartum care visit measure to what states were reporting in their EQR, and these values weren't often aligned. This was likely attributable to inconsistent definitions across the 2 data sources, as well as data quality. Data availability and data quality were also identified as common barriers to understanding and improving postpartum care measure performance. And then finally, some states are reporting and analyzing postpartum care measures that go beyond just the basic prenatal and postnatal HEDIS measures that I mentioned. For example, 8 states are reporting measures related to providing contraceptive care to postpartum women, while 6 states like New Jersey, Nevada, Pennsylvania, and Texas, they're developing postpartum depression measures. So there is some innovation and work that's happening beyond just visit rates in the postpartum and prenatal period. So in summary, our review found that most state Medicaid programs are reporting efforts to improve postpartum care through a range of initiatives. However, additional discussions and research within states is really needed to identify specific promising practices that actually improve access and outcomes, as well as quality of postpartum care. And based on these findings, as well as our larger activities that we engaged in through this project, we did identify some opportunities for CMS to better support states to improve postpartum care quality. One area would be to help states move beyond their current use of postpartum data and HEDIS measure specifications. So supporting states in disaggregating their data, as well as identifying other measures that could be used to track improvements. And then also given challenges related to data quality, particularly those inconsistencies with TMSIS and state-based data, further education about how CMS is using TMSIS data as well as its value could help improve data quality and states' investment in that data, as well as trying to better align data definitions. Thank you.
Hi, everyone. I'm Linda Jiang, and I work at Lyft Healthcare. My pronouns are she, her. I'm an Asian American woman, black top, green skirts. So to get started, I think many of you hopefully have heard of Lyft and our friends, foes down the street, Uber. But what you may not know is that Lyft Healthcare is a meaningful part of Lyft. And so at Lyft, our mission is to improve people's lives with the world's best transportation, and we see healthcare as an extension of that. One of the interesting things about Lyft that I did not appreciate until I joined Lyft about 3 years ago is that we are one of the largest providers of non-emergency medical transportation in the US. We are currently doing Medicaid rides in 24 states, including DC, covering over 70% of the Medicaid population. And so why am I here today talking about Lyft and transportation and maternal health? So if you look at this slide, we talk a lot about social drivers of health, and they're incredibly hard to address. But from our perspective as a tech rideshare company, transportation is actually relatively simple to address compared to food or housing insecurity. And one of the things that we see in the data is that those on Medicaid are actually 8 times more likely to say transportation's a barrier. I can't get to my medical care because I don't have a private vehicle, or I have to get on public transit. And so compared to those on private insurance, people are more likely to put off going to their prenatal visit because they don't have a transportation choice or an option. And so what we do at Lyft is that we use transportation as a lever, obviously to drive people to medical appointments, but also to maximize the impact of other SUHs. Like you can use transportation to get to housing access or transportation to get to groceries or healthy food access. So at Lyft, I mentioned we partner up with healthcare ecosystem players, right, to get transportation as an access point for women on Medicaid. And actually, I love this because this is an example of a health plan partnership, and they are increasing awareness of, hey, if you are pregnant and on Medicaid, did you know that you can call this number for a free ride to your medical appointment? And one of the things that we do is it's not so simple. So as you think about someone who is on Medicaid today and you're pregnant and you want to get to your medical visit, gosh, you have 12 to 20 visits throughout your pregnancy. What you have to do is you have to find maybe your health plan number. Your health plan may give you the number of your transportation manager. So you're calling into this 1-800, like call me a ride. And maybe you're waiting on the phone with them for 5 minutes, for 10 minutes. You talk to someone on the phone and you tell them, hey, I have to go to my prenatal visit a week in advance. And so they put you into the system. And the traditional experience before Lyft came into it is that you're waiting maybe an hour, 2 hours, 3 hours for your medical transportation van to arrive. And in some states, what we found was that there were multi-loading patients. And so they would pick up Jane, Sally, Bob, and then drop off Jane, Sally, Bob at their medical appointments. And so maybe, if you're looking at your day, you're like, I don't want to take off half of my day to get to my medical appointment because of transportation as a barrier. And so what we do is we work with states to really update their policies, because there are policies that we found in NEMT programs that are not necessarily conducive to rideshare. Some are easier, right? Like maybe having a placard for the name of your vehicle. Some are a little bit trickier. And so we work with them to update their policy so that rideshare can be used as a form of NEMT. And then we work with our health plan partners. We work with our transportation manager partners and our healthcare provider partners to then promote awareness that this benefit can now be used via Lyft. And so I, put this here because I like this example of a health plan actually here in DC promoting the usage of Lyft for their Medicaid members. Okay, so I talked a little bit about what that experience looks like today and, why modernizing healthcare transportation is really important to women who are pregnant on Medicaid, because now with technology and our on-demand network across the nation, you don't have to wait 1 to 2 to 3 hours to get a ride to your prenatal appointment. You can actually get a ride in 5 to 10 minutes, which is pretty amazing for these women. And what we've heard is that it reduces stigma. So sometimes a medical transportation van will show up and people don't necessarily want their neighbors or their coworkers to know that they are, taking this medical transportation van to their appointment. And so they're more likely to then want to request a Lyft healthcare ride to their appointment. The other thing that's really nice about this is traditionally, when your appointment is over, you would then have to call up your transportation managers like, hey, my appointment's over. Can you book me a ride back home? Maybe then you're waiting 1 to 2 to 3 hours. And so with our technology, we can send patients a text message. And so is your appointment over? Are you ready to go? And with a click of a button, you don't have to have a Lyft app, just any old phone will do, or you can call into our landline. We can send a Lyft to you in 3 to 5 minutes. And we believe that really breaking down those barriers, making it easier for people to get to their prenatal appointments can increase appointment adherence. Okay, so looking forward, a few things that we've seen across the board. So only about 30% of people on Medicaid are even aware that there is a transportation benefit. And so we see a lot of opportunity working with state Medicaid agencies and health plans to increase awareness of the NEMT, the non-emergency medical transportation benefit. The other thing I would love to just highlight and talk about is we're partnering now with some really innovative organizations baby scripts, for instance, and Quilted Health. We actually gave out grants this last quarter to study the impact of transportation on maternal health. And so we are providing free Lyft rides for maternal health patients, actually mostly on Medicaid, to see how breaking down the administrative burdens in the system could increase adherence to their prenatal visits. So what happens if you don't necessarily have to call up this 1-800 number? What happens if the rides are just provided to you from your provider? Does that increase your adherence to these appointments? Okay. And that's it.
Good afternoon. I guess I'm what stands between all of you and some questions and then leaving. So hopefully this will be good. It says Gregory, but only my grandmother called me that, or people when they're mad at me. So I'm Greg LaManna, I guess white male, average white male, and I'm wearing a burgundy suit, but since I went to Florida State, we'll call it garnet. And I'm going to talk about the state of Ohio work. And first off, let me say I'm honored to represent the Ohio Medicaid plans. In particular, a colleague of mine, his name is Mark Grippy. He's the CEO of AmeriHealth, who was the co-executive sponsor on this work in Ohio. And so your probably first question is like, why is he thanking other Medicaid plans, right? Their competitors. Why is he giving credit to Mark Grippy at AmeriHealth? Well, Ohio's doing something I think that does not exist anywhere else in the United States. And this, we'll talk about how we do it in a second, but essentially what it is collective impact, right? And so as we've talked about and all heard, all of the disparities, the infant mortality rate continues to go up. I think Ohio is either 48th or 49th in infant mortality. We've got a long way to go. And so having a healthy baby, having a healthy pregnancy is not something plans should be competing about, right? We want good outcomes for folks, whether you're a mom, whether you're a dad, whether you're a baby, if you're diabetic, we want good outcomes. And that's the goal. Let us compete over things like who can pay a claim faster, who has the best customer service, who's got provider innovation tools that they're using, and better member transparency. Let's remove the outcomes from what we do. And so what Ohio has done is really incentivize plans in a unique way. And it's through the quality withhold. Does everyone know what a quality withhold is? Okay, so I'm assuming everyone does. We don't earn that back unless every plan moves the needle together. So I've got a CMO. His name is Brad Jackson. Great guy, brilliant guy. The person I talk to the most is actually Dr. Mark Ratstetter, who's the CMO at Humana, because he's the CMO that's over this project, right? And so it really creates, actually the person we text the most with, right? It really creates a lot of good working relationships so that you're able to bring forth the best ideas. And so what you'll see here is we've structured it through obviously there's a macro, we play in the meso space, right? And then the micro, and we kind of try to bridge, right, state goals with really making it practical and being able to implement and sustain at the micro level. And so what you'll see is we've moved beyond the sort of one size fits all, right, that fee for service has, and kind of honored the diversity of ideas and experiences and figured out the best way to improve outcomes for everyone, right? And so what you'll see here, I think it's somewhere on this slide. We worked in rural areas, we worked in Appalachian areas, we worked in urban areas, suburban areas, and it's not a peanut butter approach, right? We figured out listening to the community, listening to our provider partners, what's the best way to leverage what we can bring into the community to get better outcomes. Okay, so real quick, the goal. So achieve and sustain 850 PRAFs. Everyone know what a PRAF is? It's a pregnancy risk assessment form. So it's a tool. It used to be for progesterone treatment. They would do this and judge your need for progesterone. The FDA, I think maybe a year or two ago, no longer recommends progesterone. So it's now sort of evolved into this more of an SDOH screening needs of the member. And so we had to achieve 850 PRAFs a month. We'll get to the results in a minute. But the baseline number was 335. So there was, on average, about 1,200 births a month in Ohio. In Ohio, 1,200 births a month. So less than one 1/4 of those members were getting a pregnancy risk assessment form. And one of the benefits of it is identifies your needs, but it also gives you the postpartum coverage. All right. So one of the things we had to do is design 3 proven interventions through using quality science. So not just 3 crazy ideas or things that you think will work, proven scientific things that show impact on the smart aim. So we chose 3: providing technical assistance providers to understand how to bill it and how to complete the form, an incentive payment structure. So we were paying more for providers to do it. And then we also developed a care guide. So in Ohio, care managers or whatever, we refer to them as care guides. Every single pregnant member, no matter their risk, got a care guide. So a lot of times plans will say, well, unless you've got a high risk pregnancy, we're not going to assign you a care manager. In Ohio, all the plans agreed together and said, if you're low risk, you're still getting a care manager, care guide, even someone just to talk to, help you navigate the system, because it's hard enough for those of us that are educated about healthcare and navigating that system. And so we implemented that solution again as an industry. We did testing, as we said, on rural Appalachian areas, urban and maternity desert geographies to test the different interventions and making sure they work at each one of those areas. We worked with Queens Village in engaging women of color, utilizing pregnancy celebration gifts, and they got to pick their own. And it was all with minority or African American owned businesses that cultivated the brochure that they got to pick from. So it was things that they said that they wanted, and it was all owned by local businesses. And then we created a member engagement focus on health literacy. One of the biggest things we've struggled with is even if a member got a PRAF, we couldn't follow back up with them. We couldn't reach them once they left the office. And so it's tough to make a difference and say, hey, we can help you get a breast pump. We can help you get a safe sleeping kit if we can't get you back on the phone, right? And so another part of this, big part of this was member engagement. All right, and so here are the results. So as you can see, where we started all the way on the left, around 330 PRAFs per month. And when we ended, we finished above the baseline, though our official score was slightly short at 844. So still almost a 200% increase in our performance. And again, we did it by working with every single plan and sort of remove the competition, remove the secrecy. If someone found something that worked, we went with it. So thank you.
So if you can tell, we tried to pack a lot into the time that we had, because we also want to make sure that we saved enough time for Q&A, because I'm sure all of this is certainly probably going to whet your appetite, and you probably do have a lot of questions. So while we're gearing up, we do have a roving mic for those of you in the room who have questions, so just raise your hand. We also, for those of you who are joining us virtually by Zoom, I believe you just insert your question to the chat box, and there's a way for us to receive those questions as well. So as you're thinking through what questions that you might have with our speakers, I just wanted to note that we've compiled just a short list of resources for you. We certainly couldn't cover everything that we would have wanted to, but hopefully these resources are things that you can look into at your leisure after the end of the conference. And of course, all of our contact information, if there are any one of us in particular that you want to reach out to afterwards. I also just wanted to make a very quick plug to say that our closing plenary session are going to be broadcast into this room. So there's no need for you to leave the room to hear the closing. Just to make the end of your day just a little bit easier. So with that, let's open up for Q&A. Is there anyone in the room? Let's start in the room. If anyone here has any questions for any of our speakers.
I'll start first with a question. If you guys want to think everything through. We have someone wondering about the availability of the Lyft healthcare rides in rural areas.
Yeah, good.
Yeah, it's a great question.
This should pick you up, I think.
Should I try it? Okay. That is a great question. So I think if you all are familiar with rideshare, it's no secret that we are obviously stronger in urban and suburban areas, but one of the conversations that we have with state Medicaid agencies all the time as they look to authorize rideshare is with these traditional medical transportation vans, we can actually alleviate their pressure because they're so supply constrained so that they can focus on the longer rides that are more rural. And for them, the urban and suburban rides are actually, they don't want those rides because they're not profitable for them. They're short rides, maybe, 5 to 15 minutes. And these traditional medical transportation providers would prefer to have the longer, more rural rides. So, to answer your question, yes, probably not great in the rural areas. It's something that we are actively working on, but we also recognize that we can alleviate the constraints in the existing system.
Any other questions in the room?
Oh, wait.
Yeah, I think I can add to that actually. So in Ohio, we've got a large rural Appalachian area. We view things like Lyft, we use Lyft, is additive, right? Like it's not going to solve the problem, but it's additive. A lot of times people look for it as extra income in the Appalachian areas if there's high unemployment, or some people use it, go to grocery stores. There's one county in Ohio that most of their fresh produce was at a gas station, right? Because the grocery store had closed, right? And so folks were using the transportation to get to another county to be able to go to the grocery store. So I don't think there's like one solution, but I definitely view rideshare as an additive solution, because to your point, the traditional providers can't cover it as well.
Hi, thank you. My name is Tracy Wayne with Elements Health. Great presentation. Really enjoyed it. My question specifically is, I look at a lot of data and I see that a woman who is pregnant and has social drivers and health need, if they're not addressed, their birth outcomes are a little bit worse. That's from the data I'm seeing within Elements Health. I'm just curious. I see a lot of measurements on the HEDIS, PPC, as well as COP. So to me, those are a little bit more process oriented metrics, structural. Are you measuring any outcomes like preterm birth, low birth rates, and then impact of having transportation? Are you seeing any, decreases because we're providing these social services? And then any ROI, it seems you are seeing anything. Thank you.
Yeah, we collect a lot of data at CMS, and one of the things that we do in the Division of Quality is we house the Medicaid and CHIP adult and child core sets, and then the maternity core set is a subset of those core sets, and it includes process measures, like you said, like prenatal and postpartum care, but also includes measures such as low birth weight, preterm birth, those kind of measures as outcome measures as well. And lower C-sections, which I guess could be an outcome or a process measure.
And I'll just add that we're also looking on ways to incorporate some measurement around social drivers of health. So going back to that earlier slide, the busy one that looked like a driver diagram where we looked at the outcomes, then the clinical drivers, the social drivers, and policy drivers. We're looking to build out our infrastructure so that we have metrics for each of the different kinds of drivers. We're starting out, and I'm actually working with Megan Wu on this. It's hard, if you can imagine, to collect social driver of health information from healthcare providers because it's not typically the kind of thing that they're collecting already, and it doesn't show up on a claim. However, they are being collected in other places, like CDC has been collecting this information as part of their birth risk data set, the behavioral risk factor surveillance system. They started collecting it in 2022. They're doing it again in 2023, as well as 2024. And their data set, they work with CDC as well to make it stratifiable by payer. So you can look at the Medicaid specific population at the state level, at the national level, and get some estimates around things like housing insecurity, food insecurity, and all the other kinds of social drivers that they include in birth loss. So it's not the perfect solution, but what we're trying to do, at least in the interim, is to really start to identify, if we're having a hard time collecting this, where might this information already exist? Can we tap into it? And then not only use it for our own purposes at the federal level, but then hopefully also feed it back onto the states, where they can actually use this information to drive some quality improvement efforts like the ones that Kristen did, and which Linda and Greg are already spearheading.
Hi, thank you. My name is Kayla Holdash. I'm with McDermott Plus Consulting. And so my questions are for maybe the other partners, thinking about my clients and just getting like, was there a strong that was like, yes, we're going to do this? Was there something that took you from this is something that's important to let's actually act? And how did you get, why was it money and why, how did you get?
Yeah. So I think it's a couple of things. We've got an amazing, and I'm not just saying this, amazing Medicaid director in Ohio, Director Corcoran, and a true visionary leader, Dr. Mary, who continues to push us, Dr. Mary Applegate. And there's a healthy tension there. But I would say probably COVID was the big push, not the maternal piece, but just sort of the idea of collective impact, right? When we joined the Medicaid program in 2022, in February 2022, COVID was, burning pretty hot. And we were tasked with, as an industry, getting over 1 million Medicaid people vaccinated, right? Staggering number, all age groups. And they said, you've got to do it together. The governor and the director, and Dr. Mary said, pulled us all in a room and said, we need to get this, we need to get this done. And, we're going to incentivize you all to work together. And I think that was really the jumping off point. And it went well. We beat the goal as an industry. We have like 1.3 million members, I think, and we met every Thursday. We had daily meetings. We meet every Thursday with Dr. Applegate as a CEO group around our progress. But it was a lot. Tracy knows we're a huge organization, right? United's a big organization. But we're changing the thinking because like the need for COVID really kind of helped, I think, be a catalyst there. And in the beginning, it was like, oh man, I have to work with someone else to really do it's like college, right? And you do these group projects. It's like, you mean to tell me that I've got this amount of money or my reputation's at stake, depending on what Mark Ratstetter does today. And so there's a lot of trepidation in the beginning, but everyone works so very well together. We each, as groups, divide up who is the executive sponsor for stuff. We assign teams. It's all the teams across all plans. It is a struggle, but you can get there. Anyway.
We can do another virtual question. For the Lyft rides, are there limits to including other family members or children to accompany the Medicaid covered patient?
Yeah, that is a great question. So in terms of other family members, you can typically include 1 to 2, as many as that would fit a typical Lyft vehicle. In terms of children, so you can bring children in Lyft ride, but you have to bring your own car seat to the Lyft ride. It is a request that we have heard from partners across the board, can some Lyft rides come with car seats? It's certainly feedback that we're considering. Probably harder for us to scale if I were to be honest, but for a lot of these postpartum visits, we do take mothers and their children, provided that the children are in a car seat.
All right, great presentation, Julia. So the first question I have is, and this could be pretty much across the speakers, it sounds like a lot of you individually led some of the activities you've done. I'm curious, were there any internal changes you had to make at your organization to allow you to do some of the work that you were doing? And if there were, maybe what were some strategies you used internally before you work with the communities externally?
Absolutely, yes. Absolutely, right? Because again, it's such a foreign concept to work with competitors on things. But we've got a really understanding organization that's great. We, certainly being a CEO helps a little bit to be like, hey, we really need to do this, right? You can go that route, but we really didn't need to. It was a lot of like just explaining the vision. I think I worked with someone years ago in Boston that said, if you can explain to people, what you're asking them to do, why you're asking them to do it, what they get out of it, what you get out of it, you're in a real good place. And so that's where we kind of started to say, look, this is the vision. We're going to lead to better birth outcomes. Here's what we've been asked to do. And, once you can do that, I think we've got a really flexible organization. But again, it is a struggle. You're going to have those conversations and kind of go monkey bar to monkey bar within your organization to get the visibility that you need to. And here's why we need to do it. But that's, I would say, just one step at a time, one foot in front of the other. But there's going to be some resistance, but I think you can navigate through it. At least we were able to successfully, I think.
I have a policy example, which I like. I'm a policy geek, but I'm also a pediatric provider by training. So one of the things you heard is the maternal, one of the leading causes of maternal mortality is mental health and SUD. And so one of the things we want to make sure we do is screening moms in the postpartum period. Brand new baby, sometimes you don't get to your postpartum visit. So one of the things that a lot of pediatricians were recommending is, can we reimburse a pediatrician for screening the mom for depression? And everyone, when you talk to policy geeks, they're like, we can't pay you for caring for someone that's not the patient. And so it was a lot of work, but we had to convince folks, surprise, a healthier mom makes a healthier baby, right? And so we were able to get that reimbursement, and we're able to reimburse pediatricians for doing a screening for maternal depression, which is something we was really excited about. Policy geek here. I think we're running.
So good. Luckily, healthier moms and healthier babies aren't always such a tough sell.
That's
That's a big part of it too.
Exactly right. Sure, there's tougher ones. Yeah.
And with that, I think we're probably at time. So if you can just join me in and round of applause about not just for their fabulous presentations, but important for the work that they're doing. It's very inspiring. It's hard work. So thank you all for sharing just a little bit of what you do with all of us. And thank all of you, both all of you in the room, as well as those of you joining us virtually by Zoom. Thank you so much. I know it's been a very long day for all of you, and we appreciate having you. And with that, I think I'm pleased to stay here for the closing plenary. I think folks can just stay in their seats and we can watch the closing plenary address.